thank you for inviting me. I'm not sure I've been described as very famous before, so I'll take that as a compliment. So I'm going to talk about using the capability approach for making resource allocation decisions for non-pharmacological interventions. So this is a quote taken from the programme that non-pharmacological interventions, or NPIs, are science-based and non-invasive interventions on human health. They aim to prevent, treat or cure health problems, and they have a measurable impact on health, quality of life, behavioural and socioeconomic markers. And what I'm going to concentrate on is the last part of that, the measurement, and particularly the quality of life element of that measurement. So just to give you an outline of what I'm going to try and cover in my talk, I'll start off just by saying a little bit about how we allocate or how we make resource allocation decisions. Then I'll talk about using a life course approach to measuring capability for resource allocation decisions. A little bit about measuring capability in practice using a set of measures called the ICECAP measures, and then how we might go about applying that to the resource allocation decisions that we have to make. Excuse me. And then I'll just finish with a couple of final thoughts. So starting off thinking about making decisions about how we spend our resources. This is clearly a really important part of healthcare. We have to think about what things we're going to do with our funding. Are we going to support mental health interventions or interventions at the end of life, or social care or maternity care, behavioural interventions, drug interventions and so on. So we have to make these choices. And the way that economists tend to think about making these choices is by using what's called economic evaluation, where we look at the costs or the inputs, the resources that go into an intervention, and on the other side, the benefits. We tend to be less bothered about the black box of how the intervention actually happens, which is probably what most of you are interested in. When we're thinking about benefit, we try to think about the person or the patient who benefits from the treatment, and we tend to conceptualize that in health economics as health, and we tend to use a very particular type of measure called the quality adjusted life year. Now, in using this measure of health, what we're assuming is that that fully represents the benefits to the individual, and that QALYs fully represent health. So QALYs may or may not fully represent health, but that's not really what I'm going to focus on in this talk. My concern is more about whether or not health represents all the benefits to patients or people, or whether actually we need to go beyond that and think about something broader in the terms of more general well-being if we're going to capture all of the benefits of an intervention. So, what basis might we have for going beyond health gain? Really, to me, it seems that what's important is that we capture what's important in terms of outcomes from interventions. And that might mean thinking about I'm English, I should be able to do this, philosophy, and what's theoretically important. And economists have traditionally focused on notions of utility or happiness associated with people like Bentham. But more recently, economists have focused on this notion of capability. So that's a notion particularly associated with Amartya Sen, Martha Nussbaum, and really particularly around human development. So what is the capability approach that they talk about? It's about focusing on what a person is able to do and be in their lives. And there's a couple of quotes here that I think are quite helpful in understanding the approach. So Ingrid Robbins describes the capability approach as a broad normative framework for the evaluation and assessment of individual well-being and social arrangements, the design of policies and proposals about societal change. And Sen himself says it differs from the standard utility-based approaches in not insisting that we must value only happiness, and sees instead the state of being happy as one among several objects of value. And I think from a health economist perspective, we can substitute that happiness word for health. So actually, when we move from the normal approach that we use within health economics to a capability approach, what we're saying is that we don't just value health, but actually health is part of a number of things that we value. We might also want to focus on capturing what decision makers want, and economists have particularly focused on that in terms of thinking about health. But perhaps more importantly, we might want to capture what's actually important to people. And the question there is, well, do we know what's important to people? And where I came into this work was in terms of interviews with older people where we were trying to get a measure that would cross health and social care. And what we found when we talked to the people about the things that should go into this measure was that actually lots of people talked about this notion of capability. So this theme of capability really arose. So people said things like, I lost all my friends when I couldn't go out. For the first time in my life, I'm dependent, which is not very pleasant. I can't go out. From another one, I can choose what I want to do. I can choose my friends. I can choose who I want to do things with. And another one, just we're able to go off. We've got financial resources to enable us to do that. So actually, it seems that this value of capability is something that is important in the population. And then in terms of NPIs specifically, we might also want to think about whether or not if we just focus on health and health gain, that captures the full impact. So this was me very naughtily stealing this from the programme, but this is the taxonomy that Greg put up earlier, which suggests the sorts of interventions of interest. And I think you only have to look at some of those to realise that if you just focus on health, you're not going to necessarily capture all the benefits to people. Whereas if you focus on what a person is able to do and be in their lives, you might actually capture more. So that's sort of the basis for thinking about a capability approach. What I want to do now is sort of present the idea of using a life course approach to measuring capability, thinking particularly about, well, what might that actually mean? And because I'm British, I resorted to Shakespeare. So this is a very famous quote around the 7 ages of man. All the world's a stage and all the men and women merely players. And essentially what Shakespeare does is take us through the seven ages of man, from the infant through the schoolboy, what he calls the lover, which I think we can conceptualize as young people or adolescents, the soldier and the judge, both adults, the older person whose sight's starting to fail, and the person at the end of life, second childhood. So actually we can see that those people may have different values at different points in their lives, and that's really what the measures that I'm going to talk about are trying in part to capture. So at the moment there are 3 measures. There's the ICE-CAP for older people, the ICE-CAP for the whole adult population, and the ICE-CAP supportive care measure for people at the end of life. And all of them use a capability evaluative space, and that capability evaluative space arose from those interviews that I talked about earlier. So they come from that perspective, but they draw on the theoretical capability approach as outlined by Sen and Nussbaum, but they also draw on the sorts of things that economists have done in terms of QALYs and the lessons we've learned from the QALY approach. Each of the measures has been developed in 4 phases. So they started off with a phase of in-depth interviews to generate conceptual attributes for the measure, really talking to people about people at the particular stage of life, about what's important to them in their life, and using that to generate the attributes for the measure, and those are all analysed using constant comparative methods. Then a second phase of going back to people and doing semi-structured interviews to check those attributes, and also to make sure that we've got meaningful wording that people can actually answer when they respond to the measure. Then there's been a third phase of valuation, and we've used a technique called best-worst scaling, which is a type of discrete choice experiment for the economists among you, used with the general population. And then each of them has had a 4th phase, which in all of the cases is ongoing, where we're trying to look at whether the measures are feasible and acceptable to people, how valid they are, how reliable they are, and whether they're sensitive to change. So I thought I'd just try and show you the measures. So this is the ICE-CAP. It has 5 questions, 5 attributes. It's a simple one-sided measure. So that has 2 advantages. One is that clinicians let you put it into their trial because it's not hugely burdensome. But the second is that the small number of attributes mean that you can use economic valuation techniques with it. So the ICE-CAP has attributes around feeling settled and secure, around love, friendship and support, being independent, achievement and enjoyment. And using the best-worst scaling, we can get values for these measures. So essentially, what this graph is showing you is an additive tariff for these measures. So if you have no capability on all attributes, you'd have a score of 0. If you have full capability on all attributes, you'd have a value of 1. And for anything in between, you can add up the different bars, essentially, to get a value between 0 and 1. That is a meaningful value that represents how important the population thinks that particular state is. So there's a similar measure for ICE-CAPO. This was actually the first one to be generated, and again it has attributes around attachment, so love and friendship, around security, thinking about the future without concern, around role, doing things that make you feel valued, enjoyment, and independence or control autonomy. And again, similar set of values that work in exactly the same way. The third measure that we have so far is the supportive care measure. It's a slightly longer measure. It has 7 questions, 7 attributes, and fits on 2 sides of paper. And the wording for the measure, the attributes in the measure, are slightly different in that 2 of them really are around suffering and suffering and health. So one on physical freedom from physical suffering and freedom from emotional suffering. 2 that are really about support, about being treated with dignity and being supported, and 3 that are more general well-being and probably more similar to the attributes in the other measure, around having a say, being with people who care about you, and being prepared. And these are the values for the ICE-CAP SCM. They're preliminary because they've not quite been published yet. But I think there's one thing that for me is particularly interesting about these values, which is that if you look at the physical and emotional suffering part of the values together, they only take up about 15% of the capability space, suggesting that they're less important than some of these other things around more general well-being and around, particularly around care. So that tells you a little bit about the measures. What I want to do is just say how well they work in practice and a bit about how we've used them in practice. So these measures are now included in more than 180 studies globally, and increasingly we're starting to get evidence regarding their validity and so on. So this is an early paper from Canada which looked at the validity of the ICE-CAPO in relation to EQ5D for falls for older adults, and found that the ICE-CAPO captured impaired mobility better and cognitive function better than the EQ5D. In terms of reliability, there's not been many studies of reliability so far. Here it performs slightly less than EQ5D, where people were talking about health status, and it seems that that's possibly because of the more socially orientated nature of the questions. And that really just starting to come through, because obviously you have to wait for longitudinal studies, is evidence on sensitivity to change. And from these 2 studies, one found in relation to osteoarthritis that the measure was comparable with EQ5D, and in relation to bladder conditions that it worked better than EQ5D. It was more responsive to clinical symptoms. So there's starting to be that sort of evidence around the use of the measure. I think the last thing I can't remember, I wanted to talk about was how we actually might use these measures in our resource allocation decision making. So in terms of economic decision making generally, we tend to use QALYs, and what we do is we look at the area under the curve for the QALY, and we use that to give us our measure of benefit. We can't do quite the same thing here because we're not anchoring the measure on death, we anchor the measure on no capability. But essentially we're trying to do much the same sort of thing. So if we're looking at years of full capability gained, our aim is to assess efficiency. So what we want to do if we're using this measure is try to maximise the total amount of capability gained within the population from the use of our healthcare resources. And the sorts of values that we've generated using this best-worst scaling method allow us to do that. So the fact that our measures are anchored on full capability and no capability enables us to do this. And we can treat death within this measure on the basis that if we are dead, we have no capability. So it's a sort of philosophical way of treating death rather than the anchoring that we would do in a QALY type measure. So the measures are different, they're not the same as QALYs. But what we can essentially do is still look at gains in capability over time. So for example, a 10-year shift for an older person from the state 22222, which is near the bottom, to 44444, which is at the top, as a result of an NPI, would be a gain of 10 years at 0.44 each, so it will give us 4.44 years of full capability equivalent gained. But we might not want to do that, so that tends to be the way that economics generally works, is in terms of thinking just about maximisation and efficiency. But increasingly, economists are also interested in equity, and one way that we might try and think about that using this sort of measure is to think about absolute shortfalls in capability. So here what we're doing is thinking really about need as being an absolute deprivation in what a person is able to do or be in their life, and really focusing our resources on those people who have need as defined in that way. So it was very similar to something I came across very early in my career when I was mostly working around priority setting, which was the 1992 Netherlands Dunning report on making choices in healthcare, where they set up a system, an idealised system of how you might make choices by sieving out those people who weren't in need. And it's the same sort of idea that we're thinking of here. So this idea is that we would think about both equity and efficiency in the same calculus, I guess, and what we'd be trying to do is to maximise capability up to a sufficient threshold, so thereby focusing on those who have less capability. If we do this, then we can still use the values to enable longitudinal calculation. But here what we'd be saying is that that value of 1 would represent sufficient capability rather than full capability. 0 would still represent no capability, and death would still be treated in the same way as being assumed to be a state of no capability. If we do that, we can readjust our values so that 1 is the sufficient threshold, and we can then estimate gains in capability over time in a similar way to what I talked about previously, but here what we get is years of sufficient capability gained. So if I give you the same example, where we'd be looking at that 10-year shift of an older person from 22222 to 44444 as a result of the NPI, only the shift from that bottom level of 22222 to the sufficiency threshold would count in our calculus. And what that would do is give us years of sufficient capability gained. But what it means is that we're concentrating on our resources on the people who have greatest need. So the use of the measures is now accepted in the UK by NPIS for social care and by the Social Care Institute of Excellence in the UK. It's also accepted, the measures also accepted by the Zorg Institute Nederland for long-term care. So the measures are starting to be used and thought about being used. So just to offer a couple of final thoughts. I think in terms of measuring capability for NPIs, there really is a possibility of capturing benefits beyond health that focus on this notion of broader well-being, but that are still within the established framework of SEN's capability approach. We can use measures that value the things that are important to people at different times in their lives, rather than going from things that have been developed by experts, for example. And we can use a framework that enables us either to focus on efficiency or on this particular notion of equity and efficiency. And we have emerging evidence on validity, reliability and sensitivity to change, and increasing numbers of translations of the measures, including a French translation that's been developed here in Montpellier. And just to say something about future research, I've recently been awarded an award by Wellcome to think about the bottom end of that life course framework. So to generate ICECAP capability measures for children and young people, but also to think about, if we're going to have different measures at different stages of the life course, how do we shift between those measures? And a third part element of that will also be to think about the end of life issue for children and young people. There's also some MRC-funded research ongoing with one of my colleagues, Phil Kinghorn, where he's leading on a project to use deliberative methods with members of the general population to actually determine what those sufficiency levels might be and to generate willingness to pay thresholds for using the measure. And as I said, it's an ongoing project involving lots and lots of people to deal with these questions around validity, acceptability and sensitivity to change. So that's really all I wanted to say. I just wanted to acknowledge a very large team of people who've been involved in this work for the last 10 years, and also to let you know that if you're interested in the measures, there is a website hosted by the University of Birmingham. There's also a Twitter account, and there's a large number of publications where you can find details on exactly how the measures were constructed and valued. Thank you.